Thanks very much. Great to be here. A little terrifying, but I guess I'll muddle through. Why am I here? Well, essentially you're going to hear about my entire astonishing career, whether you like it or not. But in particular, what I'm trying to do, I've been passionate about clinical reasoning and how doctors get to a diagnosis ever since I started working as an unemployed physicist way back when. It's been a long struggle, but eventually very recently we managed to link two different kinds of psychology. The psychology of dual process models of thinking, which I'll talk a lot about. Psychology of exemplar models of categorization, which McMaster has certainly championed in the Department of Psychology here, and which turns out to be a very good model for where I'm ultimately going, which is to explain or try to explain how doctors get to a diagnosis and how students acquire that skill. The personal odyssey, how I got here, as I say, I started off in nuclear physics, but I left physics for reasons of ill health because I was starving to death. And stumbled into the Faculty of Health Sciences here when I was still very young. I started work about 6 months after the first class entered the medical school. For some reason, they decided they should study clinical problem solving, and for reasons which remain obscure and are completely beyond comprehension, they decided exactly the right person to do that was an unemployed physicist. They were dreadfully wrong. We muddled along and we started studying models of clinical problem solving without any theoretical or methodological or anything else framework, because I didn't know from nothing back then. What we did was put docs in a room with a standardized patient, a person trained to simulate a disease. I came in at the technology end and we videotaped everything, and we had sexy microphones and sexy black and white reel-to-reel recorders. We videoed these docs and these students, and then we went back to the videotapes and tried to figure out how they were thinking. And what we discovered is essentially that docs thought exactly like students did. It's just that they thought better. And I'll get to some of the specifics of that in due course. As we'll see, what really happened then was that it turned out that, as near as we could tell, there was no model of general problem solving. Rather, your ability to solve a diagnostic problem was really heavily related to basically how much you knew about the problem. And that led all of us to run helter-skelter away from the idea of a problem-solving process, more towards trying to understand how that knowledge was organized. And it's about that time I had the extremely good fortune of having a crappy old car that wouldn't run. Because late one January night as I was heading home and my car was dead, I bumped into this guy named Brooks. And I asked for a ride home, and Lee, being the generous individual, which he is in all sorts of ways, offered me a ride home. And at some point we turned to each other and said, well, what I'm doing is okay, but I really admire what you're doing. And we used practically the same words. And that was the seed of a collaboration which has gone on for 2 decades. And a collaboration to which I'm extremely grateful. It turned out that the way that Brooks and his colleagues in cognitive psychology in this building were thinking about everyday categorization was a really good model for the kind of problems we were facing in trying to understand expert diagnostic categorization. And that sort of guided the quest for the last 15 or 20 years. And then recently, just in the last couple of years, I discovered there's a whole parallel branch of psychology called dual processing models that they're not talking to us and we're not talking to them. But as a consequence of discovering this recently, I've managed to make some bridges back and forth, and that's really what we're talking about today. But since it's late Friday afternoon and you're here more to be entertained than to be educated, let me start entertaining you. Let's engage in a few everyday diagnostic challenges and then reflect on exactly the process we went through. So my first challenge is for you to try and tell me what categorization all the next objects are. Oh, there's none there yet, but what about these? Chairs. Well done. In fact, they're IKEA chairs. You may not have noticed that, but for those of us who are passionate about such things, those are all right out of the IKEA catalog. But now let's reflect on that. How did you manage to do that instantly? I presume all of you got that right, by the way. See, you're not that asleep. Imagine trying to formulate the mental rules that make a chair. Just reflect on that for a minute. Try and think about if you were to describe in a textbook with words how I should go about recognizing chairs. Just think about what might go in that chair rule. It would have 4 legs, I guess, but it could have 3 legs, couldn't it? Or maybe even 1 leg, or I guess it would have a back, but so do sofas, and it's kind of hard. But I suspect what you'd come up with is kind of something that describes that thing pretty well, but probably doesn't describe that thing well at all. Or that one. For those of you who didn't have the benefit of the flower child era, that's a beanbag chair. So the question then is, what's going on here? How is it that you can recognize the chairs instantly, instantaneously, and with absolute accuracy, but you can't tell me how? You can't give me an instruction booklet on how to recognize chairs. What's going on here? That's the challenge that faces us, because it turns out, surprisingly, that's a good model for how doctors do what they do too. Essentially what I'm going to argue is that a key element in all that is similarity. And it's not an original argument. As I say, it's a good model of categorization for both chairs and diagnoses. And so what I really want to do is then take the idea of a kind of processing that involves similarity judgments a little bit further. Let's try another diagnostic task. This is a hard one because there's actually two categories to be distinguished, and there's a tremendous amount of variation within the categories. And I'm going to show you very small sort of elements of each category. So the first task was easy. This one is a lot harder, okay? It's a lot harder because it's a... Cats and dogs, you did it! She's good. Can you take a course with me? You're really good. Okay, so what are the features that discriminate between cats and dogs? How can we tell them apart? I have 3 cats and 2 dogs at home, so I'm pretty good at this task. The ears? You've got to account for German shepherds as well as floppy hounds. That's not going to work too well. Anybody else? Sorry? Well, cats have exposed claws too, but you're close. No. You've got to deal with bulldogs. You've got to deal with tigers. So size doesn't do it. Whiskers doesn't do it. By the way, I have whiskers, but I'm not a cat. It turns out he's close to the mark. Does anybody want to refine his rule? Cats have retractable claws. There's another key element which is actually on the slide. Eyes. Cats' eyes do this and dogs' eyes do that. The thing is, though, that helped you on that one, and that was deliberately planted there, and that may have helped you on that one, except you couldn't see the claws retract. But it surely didn't help you on any of the others. So again, I'd like to suggest to you that what's really going on here is that essentially you're approaching the cats and the dogs the way you're approaching the chairs. That without being aware of it, you're matching against a large number of cats and dogs you've met in the past. And that you're not actually doing any kind of analytical rule-based processing. But instead, without being known to you, you've automatically matched to something in memory. And that turns out to be the right model, I think. Just to illustrate, I mean, the alternative is that you're actually unconsciously accessing some kind of internalized rule. And so I'd like to rule that one out by example for the moment, because I'm about to give you an easy diagnostic task that's much easier than the first. Certainly for a computer, much easier. For those of you who have taken abnormal psychology, this is a very classic rule, a kind of an additive rule that typifies everything you see in DSM 3, 4, 5, 6, 7. Okay? These are 2 very simple categories, much easier, all right? Can you tell me what the 2 categories are? I have to thank Lee for this example, by the way, but it does really effectively illustrate the point. Gee, there's a lot of silence and no answers. Huh? So what? Speak up. Sorry? I'll give everything on the left is in one category and everything on the right is the other. It's Lee who coined the phrase DATS and COGS for obvious. The tail length? No, sorry. The what? No. You see, every time you come up with a feature, there's an exception to the rule. But let me show you how you actually do it. It's a simple additive rule. I told you that. So simple. And you can see there's no within category variation at all. The head. No, not the head. Look. There's the head. Oh, no, not the tail. Look, there's the missing tail. Darned rat. It's an additive rule. What you do is you take that little critter there and you slice them into 4 bits. A tail, legs, a body, and a head. And you do the same thing for that, and then you reassemble them. And everything on the left has 3 cat features, and everything on the right has 3 dog features. And the astonishing thing is there's much less effort for the computer here. There's no within category variation. You don't have to deal with chihuahuas to mastiffs and lions to little kittens. And it's a simple rule, the kind of stuff that permeates DSM 3, 4, 5, 6, 7. And you stared at it, and you stared at it, and you couldn't see it. So the notion that you're working on an internalized rule seems like it just doesn't kind of fit with this kind of experience. I can't resist. So maybe they're not so different. What's going on here, actually underlying this, and part of the point I'm trying to make is there's actually two kinds of similarity going on. Again, by illustration, those are killer whales, which are actually a dolphin, not a whale. Which are they more like? The answer is it depends. If you're talking about conceptual similarity or perceptual similarity, the killer whales are an awful lot more like penguins, particularly from the photographs I've chosen. They both are black on top and white on bottom. They have some kind of sort of forefin. They swim underwater. They eat fish. They have all sorts of similar characteristics. And yet, of course, we know that's the wrong answer. This is the right answer. Killer whales are a lot more like elephants because we know underlying anatomy and physiology and all that stuff. The point being that those two ways of doing similarity, in fact, I will argue, mirror two kinds of fundamental, underlyingly different psychological processes. And that's where we come to dual processing theories. That by illustration, what I've engaged you in doing is two kinds of processing from the outset. One which is involving unconscious similarity matching against prior examples you've met, that you weren't aware you were even doing it, that's highly contextualized, that deals with an enormous amount of variation, and a second, which is the one that we in universities tend to prize, the analytical processing feature by feature against some kind of explicit rule. And it turns out that these two processes have been described in this whole literature going back about 20 years, called dual processing. And as I indicate, the argument that follows from the dogs and cats example, and that I'll show you evidence for, is that in fact, when you're matching against something in memory unconsciously, you're not matching against a prototype for each category. You have a whole bunch of individual beasties in the dog category and a whole bunch of individual beasties in the cat category, and quite unbeknownst to you, you're picking out one of them to match against. Again, one more example, and then we'll get on to some serious stuff. Let's talk a little bit more about those two kinds of thinking, and I'll give you another little video example. So system 2 thinking, the analytical thinking, is essentially playing by the rules. That's internalizing the rules, being able to explicitly count features perhaps against particular rules. This is an example of that with a little luck. Here we go. Anybody recognize the commercial?
At Liberty Mutual, we know all your possessions are valuable.
I can't tell you how many hours of negotiation it took to get that sucker. Hours on hours. I had to deal with unions in Boston and the whole bit. The point is that what they're trying to do is caricature that even that crummy little crystal dish is something that Liberty Mutual will cover on your insurance policy. My point is that that's a weird way to describe a crystal dish. And yet that's the way DSM-4 would describe a crystal dish, but not the way we would think about it. I mean, now, this is one way. People have characterized that kind of thinking, and here's a guy called Feigenbaum talking about experts really become masters of symbolic data systems. They build up a repertoire of rules or heuristics that combined with book knowledge make them expert. That is to say, the expert essentially has internalized rules and internalized heuristics, and the expert is not an expert because of the experience he's had. Let's go over to the other point of view, the system 1 point of view, which is basically, I've seen it before and here it comes again. This has become really popular in the literature of late. Malcolm Gladwell published this neat book that you can buy in any airport. Unfortunately, he didn't know about any of the research, but he gave us some great stories. It seems almost implausible to think that we walk around with enough examples in our head to pull this thing off. It seems like we just don't have enough memory. But of course, if you know psychology, you know that long-term memory is fairly infinite. But one of the questions which I can't answer, but I can, again, by illustration, show you something that suggests an answer is, How many examples does it take to get the job done? How many dogs do we have to meet before we can categorize dogs? To show you the example, I'd like to introduce you to my granddaughter. Isn't she cute? She takes after her grandmother. That's Julia Autumn Norman. She was 1.5 years then when this video that I'm about to show you was taken. And the video came about because one day we were over there and Mom said, Julia can recognize dogs now. And I said, big deal. And she can generalize. And I said, excuse me? She can generalize? Really? That's interesting. Now at that age, Julia couldn't say dog. She could not speak any words other than maybe mama. But what's this? Now, watch this, but so to go, yeah, yawn, so big deal. So we gave her the puzzle, and she's learned how to do the puzzle, right? She's learned that, where's the dog? And she points to the dog. And where's the cat? And she points to, yeah, good for you, Julia. Well done. Well done. So what Julia has learned is that if she puts that thing over there, then Mommy gives her a popsicle, right? That's straight behaviorism. Well done, Julia. But watch what comes next. They pull out an adult magazine, House and Garden or something like that. On those pages are 6 photographs of proud families. And there's a dog over there, and there's a dog over there. And Julia's never seen that book before. The high tech is due to my son. Well done, Adam. What's interesting about that is that her parents didn't even know there were 2 dogs on those pictures. They'd only noticed one of them. But Julia, who could not say dog, who is limited to very few dogs, is already capable of identifying dogs in those kind of very, well, let's go on. She's able to pick out 2D abstractions of dogs, very complex 2D abstractions. She clearly couldn't be analyzing the features, at least not at any kind of conscious level, because she can't say the features. She has no language yet. And she can generalize. With the limited repertoire of dogs she's already met, she's already generalizing to the whole category in all sorts of positions that dogs come in. Well, that's good anecdotes, but it ain't science. This is a nice quote about the whole idea of non-analytic processing. And basically, Dreyfus is arguing that, in fact, you become an expert by beginning with the rules and applying them to many examples so that you have rich, complex categories based on examples which follow from the rules. Okay, here we go. We're going, after all, ultimately not to everyday categorization, but to diagnosis. And to do that, I'm pulling in this dual processing theories of thinking with theories which have a large McMaster smell about them, about concept formation and categorization to the service of understanding clinical reasoning. First, a bit more about the dual processing theory then. You've already seen this kind of definition. That's familiar. It turns out there's very recent evidence that this is not just a model. This is not just some kind of boxes and arrows, but rather that, in fact, good old functional MRI comes to bear and shows that, in fact, those kind of processes operate in different parts of the brain. So the neuroanatomy is identifiable and different for the 2 kinds of processes. And then a really cute study that was done last year, which what they did was they brought a bunch of the ubiquitous undergraduate psychology students in, and it was a 2-part experiment where part 1 was rating a particular brand of lemonade, and part 2 was doing a categorization task. Except that one group had lemonade with saccharin in it, and the other group had lemonade with glucose in it. And they got them involved in the brand rating, and then they waited a half an hour. And what they found is system 2 processing is literally energy intensive. The group that had glucose in their lemonade shifted from 17% analytical to 47% analytical compared to the group that had saccharin. The nature of the attraction effect doesn't really matter. What does matter is that the act of ingesting glucose provided enough energy reserves to shift the nature of processing by a significant degree. So dual processing is alive and well as a thinking process, but what it doesn't tap into, it taps into, if you like, my mental model is it gets you It talks about where the wires are connected, but it doesn't tell you what's at the end of the wires. And to that I'm going to bring in exemplar models of categorization, championed by Brooks and Jacoby and a number of other people in cognition here. There's been a number of models of what the mental representations might be, but basically what I'm going to pursue is primarily exemplar models of categorization. Doug Medine in Chicago, Lee Brooks right here, and a few others. And their basic argument is that categorized natural categories and, as it turns out, diagnostic categories essentially are populated by a whole series of examples, and that the examples themselves define the category. That's why you couldn't tell me the rules of a chair, because your chair is essentially a conglomeration of a whole zillion chairs you've met in your career, and you haven't abstracted a rule from it. So, here we go. The issue then is, how do we go from the theories about everyday reasoning and everyday categorization to medicine, which is where I wanted to end up. To begin with, going back to my prior career, let me begin by pointing out that we began with the idea that medical expertise and medical diagnostic expertise was some kind of elaborated process, and that as you went from novice to expert, you got better and better at the problem-solving process. That turned out to be dead in the water. We did find that there was a process, and the process involved generating multiple hypotheses very early on in the encounter with astonishing little information. I've just been recently reviewing transcripts from expert physicians who are coming up with obscure diagnoses on the basis of the first sentence that a patient utters. How do they do that? Well, that's the challenge that faced us, because that seemed to characterize clinicians at every level from first-year medical student to expert. And boy, did that matter. This is a study from those bad old days when I was transcribing all those videotapes. What we found is that if you thought of the correct diagnosis in the first 5 minutes, your chances of ultimately getting to the correct diagnosis was about 98%. If you didn't think of it, your chances were about 25%. So you could argue that all that stuff that happens when you go to your doctor about, and have you have a family history of that, and have you had any colds and any headaches, and this and that and the other thing, that's just fluff. If they thought of it early, they're there, and if they haven't thought of it early, they're not going to get there. So let's think then, by analogy with what we've been talking about till now, what makes an expert doc a doc? I've already kind of already segued into the idea that it's his experience, but let's elaborate on that a bit before we get to the studies. Because the challenge I want to throw up to you is, it seems on the surface that medical diagnosis is not at all the same as what we've been talking about. After all, medical diagnosis, students spend donkey's years learning all those rules of diagnosis, right? And they pore over Harrison's textbook of internal medicine, which tells them the signs and symptoms of this, that, and the other thing, and the 29 causes of anemia. It seems that that's the essence of medical expertise. Or is it? Let me ask you, engage you in this test. Now, you folks are probably, most of you, not all of you, but most of you are young enough that going and finding a family doctor is probably not high on your list of priorities anyway, but for us old farts it is. Give you the challenge of picking one of those two doctors. How many of you picked the first one? How many of you picked the second? Well, the old farts say the second, everybody else abstains, it seems. When I play this out with clinical audiences, it's like 99.5% to 0.5%. Everybody goes to the second example. So everybody at some level is weighting experience far more than formal knowledge. And I always ask physicians another question, which goes like this. How many years after you finished your specialty training before you felt you were competent? That's a kind of a scary question for patients. But in fact, routinely, physicians will say about 5 more years. In other words, it took them about 10 years of experiences beyond their acquisition of the formal knowledge as undergraduates before they felt they were competent. So what's happening in the 10 years? That's the conundrum. Why do you prefer the candidate who has less competence but more experience? What is that candidate getting from those 10 years of experience? What is the physician getting from the 10 years of experience? I argue that she's getting 10 years of experiences. Let me show you some data about what happens to the formal knowledge. There have been studies of what happens to the formal knowledge of physicians from the moment of graduation, and it's not a pretty sight. That's scores on a multiple choice test from years of graduation, and as you can see, it's the scale's expanded, but still they're dropping by about 20% over the 4 decades of practice. So the conundrum is that on the one hand, their formal knowledge is dropping away, and yet somehow the experiential knowledge is the thing that we really value when we're trying to pick a physician. What's going on there? Well, let's now finally turn to the data. Because what we're going to argue from the data is that essentially what's going on is that they are acquiring all these experiences, and that the experiences become a major determinant of how they do. So, question, how does that experiential knowledge get into memory? And ultimately, how do they coordinate that experiential knowledge with the analytical knowledge of the textbooks? Well, old study. What you have to recognize is that there's no point in asking a physician who's just diagnosed you as having lichen planus which patient they were thinking of, because as you saw with the chairs, you're not aware of what chair you were thinking of. Or the dogs. You don't know what dog you were thinking of, you just know it was there. So what we have to do in order to show the role of prior experience is to control prior experience. Essentially, we have to create 2-part experiments where under one cover story or another, we effectively control the prior experiences, the specific prior experiences, and show the influence of those specific experiences a half an hour or 2 weeks or whatever later. And that's how we go about it. So this is, first of all, I forgot about this one, so bear with me. First of all, as a first marker of whether the docs are using System 1 or System 2 processing, we can simply look at response time. And the idea is this. When a doctor is correct, is he fast or is he slow? Now, if you read the literature in medicine, they'll say, well, the reason the docs make mistakes is because they take shortcuts and they're going too fast and they're not gathering all the data and they're not systematic and they're not thorough and they're not all sorts of blessed things. But if he's using System 1 processing, correctness should be associated with speed, positively, not negatively. So, here's a study we did a zillion years ago with 100 slides, and we just looked at 6 levels of expertise from medical students all the way up to dermatologists. And we looked at accuracy and response time. First of all, accuracy sure won. The dermatologists were bumping off at about 85% accuracy on those slides. The medical students down here at about 20%. But look at the response time. When they were right, the response time dropped from 12 seconds looking at the slide down to about 7 seconds looking at the slide. When they were wrong, went from 12 seconds. The medical students, by the way, they knew they didn't know. You know, they knew warts and they knew acne, and that was about as far as it went. And so they knew they didn't know. But when the docs were wrong and that ever-diminishing number of wrong answers, their response time went up. And when they weren't sure what they were dealing with, it was up to 26 seconds for the dermatologist. So if you don't go to a physician and the physician says, I'd just like to think about that, find another doctor. Let's turn then to how we show that what they're really doing is marshalling prior examples they've met. Classic study, which we did with dermatology, again, because you can control experience really rapidly. We took a bunch of medical students. We taught them on 6 different dermatology conditions. They taught the rules. They practiced the rules with a bunch of verbal examples. The rules were always in front of them. And then we trained them up on a bunch of slides. Each one of those categories had 4 slides associated with it, and they went through the whole batch 5 times until they got them right. And then we tested them with a bunch of new slides, of which 9 of the 30 new slides were critical slides in terms of their relationship to the training set. In particular, so here's one example. The training set, one group saw contact dermatitis on a chin and lichen planus on a forearm. The other group saw contact dermatitis on a forearm and lichen planus on the back of a hand. Now, lichen planus can occur on extremities, but contact dermatitis can be anywhere, and the rules were in front of them. But then we showed them this. And so explicitly and analytically, they realized that being on a forearm shouldn't matter. But boy, did it. If you're in the yellow bar and you saw contact dermatitis correctly on the forearm and the other 8 examples, your overall accuracy is about 90%. And you're relatively very unlikely to mention the incorrect lichen planus diagnosis. If, on the other hand, you saw lichen planus on a forearm, your chances of getting to the contact dermatitis dropped to about 40%, and you're much, much more likely to call it lichen planus. In other words, even though the rules were there, they were explicit, the fact that you saw it on a forearm and you'd seen something like that sucked you in. Well, maybe that's cheating because those are visual pictures. They're very vivid. They're very memorable. So let's try something else. Does it apply, first of all, to verbal information, and does it apply to information which is objectively irrelevant? Because with the skin pictures, we can't really dissociate figure and ground. It's all sort of mushed together. So we did this study where we took medical students and family medicine residents, and the cover story was to review electrocardiographic diagnosis. And they saw a total of 11 ECGs, of which 4 were ringers. In those 4, one group saw a middle-aged banker with chest pain, and the other group saw an elderly woman with chest pain, and that was the only historical information they were provided. The diagnosis was an anterior MI. At test, they saw a middle-aged banker with chest pain. Another thing which looks like an anterior heart attack, called a left bundle branch block. And 4 of the 7 test slides were the critical ones in that they matched or unmatched on the prior demographics. If exemplar theories are working, what we should find is that the people who saw the middle-aged banker are less likely to get the right diagnosis of left bundle branch block and more likely to call it anterior MI, even though it's verbal information, even though it's objectively irrelevant. This was such a smarty-pants study that the woman who did it with me kept it in the bottom drawer of her filing cabinet for a year on the basis that this one could never work. But of course it did, or I wouldn't be talking about it. The group that saw the old elderly lady and was not confused had overall accuracy of about 45%. The group that saw the middle-aged banker had an accuracy of half that, 22%. Even though the data were objectively irrelevant, even though no resident would ever stand up and say, well, he was a banker, and a couple of weeks ago I saw a banker. Nobody would do that. But they did it. So what we've got from those sets of data is essentially exemplar-based reasoning is the driving force behind medical diagnosis, just as it is behind everyday categorization. The categories and concepts are based on our specific experience with the world, and you become an expert by learning a whole bunch of those categories. Is that all there is? No, of course not. Do experts ever go back to the analytical data? Do they ever reason it out? Well, yes. And here's an example of that. We got together, there's 3 ways that, I'm going to say we'll start here. When, medical students spend a lot of time learning basic science. Do they ever use it in practice? Well, some do. Most of them do it rarely, and I'll talk about that briefly. Some, like nephrologists, as we'll see, use it when they get to difficult cases. And then there's intensivists and anesthesiologists and critical care folks. They're an odd breed. They're all applied physiologists. They use it all the time. But let's talk about the middle category. That is to say, I want to focus on these people. When they use it, do they use it with difficult cases? Do situations arise when the expert says, something funny's happening here? Let me go back to the basics. And what we did was create a series of 8 really, really ugly nephrology cases. Now, nephrology is number 1 on the hit parade of things that medical students find hard to learn anyway. But these were such hard cases that I remember distinctly one of the nephrologists, the sweat was pouring off his brow. And he was about 15 minutes, and he said, my God, am I done yet? We said, you're only about halfway there. He said, this is like the worst day at the clinic ever. And it was just a bunch of little written cases. But he was engaging in so much mental effort to get through these suckers, it was really hurting. So we had, our novices were a bunch of family medicine graduates. Our intermediate group was a bunch of internal medicine residents, and then the 4 nephrologists. First of all, we got the diagnostic accuracy down right. The nephrologists were knocking it off at 90% accuracy. The family medicine residents, who are doctors after all, 25% accuracy. Ooh. What was neat, though, was that the way the nephrologists did that is that they had far more causal explanations for their hypotheses than either of the 2 senior learner groups. So under these circumstances, clearly the nephrologists were really invoking a whole bunch of basic science information to get there. And that showed up in ultimately in their diagnoses. That is to say, the family medicine residents couldn't think of any hypotheses as to what might be going on. The internal medicine residents and nephrologists thought about the same number of hypotheses. The nephrologists were more accurate, but used about half as many investigations to get there because they knew what they were dealing with. So you could say that in difficult diagnostic situations, this provides evidence that, in fact, that's when they go back to the harder, much more energy-intensive System 2 kind of thinking. You could say, but I have to share two anecdotes with you. The first anecdote was the chair of family medicine here, who started to spontaneously describe recently when he was in the clinic one afternoon and he saw a kid with a sore throat and, sore ears and sore throat, and he said to Mom, the usual routine is probably just a viral respiratory infection. Take the kid home, give him an aspirin, give him lots of fluids, and if he doesn't get better by the morning, give me a call. And an hour later he said, there's something wrong with that one. And he phoned the mom and said, get that kid into the emergency room now, or else he might die. And the kid had something called tracheitis, which you can suffocate. Your trachea swells up, you die. And I said, David, what was it that clued me? He said, I have no idea. I have no idea. So maybe the basic science is there, but maybe it's still System 1 thinking operating. Last week I was having a beer over in the Phoenix with an emergency doc who was bemoaning the fact that he's now working out of St. Joe's, and one night in a 1-hour shift he saw 75 patients. No, in a 6-hour shift he saw 75 patients. Things aren't quite as bad in this healthcare system. In a 6-hour shift he saw 75 patients, including, of course, the inevitable 50 H1N1 flus. But buried in the 50 H1N1 flus is one kid. And again, he said, something was bothering me about this kid. He didn't know what it was, but something was bothering him. And he went further and thought about it a bit, and the kid had something called Kawasaki disease, which is extremely rare. And if he hadn't caught it, that kid would be dead of a heart attack at age 20. But it looked just like another flu. But something twigged, and he could not verbalize what was going on. So even though when we did that study, I was prepared to say basic science is something that you revert to when things just don't fit together. It may not be as simple as that. Perception, dual processing and perception. What this is saying then is that essentially you're recognizing the doctors are recognizing those cases almost before they can verbalize what's going on. If that's the case, then those hypotheses that are coming in so fast and are on a System 1 basis might actually influence what they see. And this is one of our students did this. Well, to those of you who know a bit about psychology, cognition, it's kind of analogous to the word superiority effect, which the word superiority effect says that if I just flash those things on a screen, you'll be far quicker recognizing rink and bink than you are NRIK. Because these are word-like, but you're recognizing the K in rink and bink faster than the K in NRIK. Now, we tend to think of things as being built up. You start with the elements, then you get to the letters, then you get to the words, then you recognize the word. But what the word superiority effect is saying is that essentially the whole pattern is being imposed rapidly on the individual elements. And similarly, if that's the case, by analogy at least, it could be that the doctor's hypothesis is being imposed on what they see with the patient. And this was Vicki LeBlanc doing her PhD thesis with Lee and myself. What she did was take textbook examples of classic signs and symptoms and then combine them with a story that was consistent, was correct, and with another story that was similar to but different. So 20 residents and 20 final year medical students, 8 photos taken from clinical diagnosis textbooks. This is the best those authors could come up with to illustrate the point. And she combined them with either correct or incorrect history. Of course, you can recognize what these things are. Well, this kid on the left obviously has a swollen jaw sort of thing. That can be Cushing syndrome, and that could be called a moon-shaped face. It can also be mumps, and it's a swollen parotid gland. And then this guy over here, he's obviously in a very serious way. He has a cancer, but it could be kidney cancer because he looks kind of yellow, but it's actually stomach cancer because there's a supraclavicular node, a big fat lymph node sitting behind his collarbone. And that's apparently diagnostic for stomach cancer. What we found is you team it with the right history and you get the right answer. You team it with the wrong history and you get the wrong answer. In short, and it doesn't matter whether you're a student or a resident. In short, what you're thinking of is a major determinant of what you see. As Marshall McLuhan, that famous psychologist, said, if I didn't believe it, I couldn't see it. But that's happening on textbook examples, the best that author could do on illustrating those physical signs. I won't bother with that. So, given that that's the case, what's the relationship between your use of System 1 processing and experience? Well, we presume that the more experience you have, the more you rely on it. Is that so? Here's a study done by one of our students, Shen Maruzi, where she's trying to get at the extent to which people are being influenced by the literal rule, the individual features, the verbal rules, versus the pattern. And a clever study she came up with. She took dermatologists, general practitioners, and residents with 36 skin dermatology slides. One group first saw a gold standard card-carrying description of what was on that skin lesion, as offered by a dermatologist. They went through that whole series. Then they saw the picture and could revise their judgment. The other group just saw the picture. So you had three conditions: picture, picture plus description, description. Rationality would say that since that's a card-carrying gold standard dermatologist description, you're going to do the best with the description and the photo, and worse with just the picture. And that's true if you're a resident. Actually, it's not quite true. The resident does best with just the description, suggesting the resident is simply applying the rules that they know about lichen planus. They don't do quite as well when you give them the picture. That confuses them. But if they only have the picture, they're considerably worse. However, there's the GPs and there's the dermatologists. The perfect verbal description hurts them. Why? Because presumably when they see the picture, there's features that are present but are non-contributory or even confusing. When they see the picture, they discount those. They only see what they want to see. You give them the description, they can't discount. And so they end up weighting things which are inappropriately weighted. So it really seems that from that set of data that as you become more experienced and gather more experiences, you rely more on System 1 kind of processing. A more recent study shows that that's not just pictorial. This is a study done by Meredith Young, who just graduated this year. Very small data set right now because she wasn't intending to go after this. We use a sample of 4 residents, but they were just kind of going along for the ride. What we'd forgotten was that the shift with experience. These are graduates, these are medical students. What she did was the most bizarre thing. Took a bunch of psychiatry cases, trained a bunch of standardized patients up on psychiatry cases, where there was actually 2 possible diagnoses. And then they went through what we call an OSCE, where they went from room to room talking to and seeing that patient. And then they'd go to the next room and see the next patient. This is a standard evaluation method where they would see a total of about 10 patients. But buried in all that, early on they saw a prototype bipolar disorder. And then later they saw a case which was deliberately bipolar and personality. It had features of both. And the question is the extent to which the early one would influence the late one. The only matching was on stuff that was extraneous. It ranged from John McLeod, the 37-year-old teacher with 2 young girls, to James McKinley, the 35-year-old teacher with 2 young boys, all the way through to one of the sets was 2 identical twins. Cunning. The question was the extent to which the first one would influence the second. Turns out if you're a medical student, basically it didn't. But if you were a resident, you were 65% likely to call it consistent with the one you'd seen before and only 15% likely to call it the alternative. So that non-contributory information had an enormous impact on the 4 residents' calls and none on the medical students. Why? Because the medical students are caught up with the features. What about age? Same sort of thing. Obviously, age and expertise are positively related. This study done by Kevin Eva, yet another one of our gang. What he did was take 8 cases, each of which had 2 possible diagnoses, and then presented information for diagnosis A early and diagnosis B late. But what he did was gradually notch up the vividness and the relevance of the later information. So this was fairly non-contributory information to extreme information that should make you switch to the second diagnosis. So essentially you got data early saying it's diagnosis A, but as time went on you got data later saying it's diagnosis B, and that data became more and more salient under different conditions. And of course everything was crossed over as we tend to do. And then he did it with younger docs and older docs. And what you see was that indeed, although everybody shifted from diagnosis A to diagnosis B as the salience of the information varied. For the younger docs in yellow, they really did shift, so they were pretty well symmetrical, pretty well balanced. The older docs never really abandoned diagnosis A. So they were much more prone to using the early information in their presumably System 1 thinking. Finally, so to wrap it all up, lots and lots of evidence that in fact there's two kinds of processing going on. Lots and lots of evidence that in fact as you acquire experience you rely more and more on System 1 or pattern recognition or prior examples. I'm now going to show you a bit more evidence because at the end of the day I suppose I have to confess to some degree of practicality that somehow I do, I suppose, want to make the world a better place. And I could do that by understanding reasoning, so presumably I could improve it. So what can we do to improve it? Well, one of the things we can't do is caution people to not use System 1 processing, any more than I could say, for goodness sake, don't think of that as a chair. Because it's unconscious, you can't control it. In any case, it's pretty adaptive. Why should we control it? But what we can do is essentially encourage people to actively use both kinds of processing. And these are a series of studies primarily initiated by Lee Brooks with a few other people. So basically what we're doing in this couple of these studies that I'll just allude to, one is to contrast instructions which are essentially pushing you both ways. Think of the first thing that comes to mind and then consider the features, versus instructions that says, no, be an objective scientist, gather all the data, carefully identify the data, and then decide what's going on. With the ubiquitous undergraduate psychology students, what we find is that the students who are encouraged to use their prior experience, however limited it may be, actually had about a 20% advantage in accuracy over the students who were cautioned to not think of things, but to rather gather all the data and then match the data to the rules in front of them. My colleague Hank Schmidt in the Netherlands did a similar study only with internal medicine residents, but here he elaborated the idea a bit. He used the same kind of instructions, but he categorized the cases as being simple cases and complex cases, and found that with the simple cases you're better off to try and think if you've seen it before, and with the complex cases you're slightly better off to try and apply the rules. So that brings us to the end of the story. We're just beginning to start playing around with questions like, can we build in direct assessments of System 1 processing? Can we get up better instructions to facilitate both kinds of processing to improve accuracy? But I've got to have something to look forward to. So a few last words from other people. Dreyfus, the expert, does not solve problems. He doesn't even think. He just does what works, and of course it works. He's not following any rules. He's just discriminating thousands of special cases. Dreyfus again, to preserve expertise, we must foster intuition at all levels of decision-making. Otherwise, wisdom will become an endangered species of knowledge. And then finally, if you want to look like a good academic, you have to find some ancient philosopher and anchor back to that. Now, I couldn't go back as far as Plato because I don't read Greek and I've never been interested in Plato anyway, but Alfred North Whitehead, 1911, it's kind of a neat quote. There's a profoundly erroneous truism repeated by all copybooks and by eminent people making speeches. We should cultivate the habit of thinking about what we're doing. Precise opposite is the case. Civilization advances by extending the number of operations which we can perform without thinking about them. Operations of thought are like cavalry charges in a battle. They're strictly limited in number. They require fresh horses, and they should only be made at decisive moments. That's it. Thank you very much.